So my name is Shazia Sadiq. I'm a gastroenterologist and health services researcher. I also do implementation science work. I'm joined by two of our expert analysts, Julie Frick and Matt Mitchell, who really know the ins and outs of systematic reviews, clinical guidelines, and we're really fortunate to have the two of them from our Center for Evidence-Based Practice. So I'm going to get started for today. We don't have any conflicts of interest that are relevant for today's talk. We are part of the Agency for Healthcare Research and Quality Evidence-Based Practice Center, and then some other just financial awards that we have. So we're going to spend the beginning part of this talk is going to be a little bit more of a didactic, just to give a really big, brief overview on what are guidelines, what are systematic reviews, and just like the basics, how can you tell if they're good quality? And then we're going to try to make this a little bit more hands-on for you. So we have two guidelines, and we chose maternal health, given all of your interests here. And thank you guys for suggestions as well when you registered. And one is going to be a guideline that comes from ACOG, which is one of the OB-GYN societies, and the other one is coming from the United States Preventive Services Task Force. And what we're going to do is we're going to try to show you in this beginning part how to assess guideline quality, and then break you out into sessions, and you'll have each of our experts in the room with you to talk through what are like strong aspects versus less strong or weaker quality aspects for those guidelines. And then in your little group, if you can select one person to be a spokesperson, we're going to come back after about 15-20 minutes and report out the findings about what are areas that you thought were good or not, and maybe potential issues that you might have if you're trying to implement this in your local population. We'll end after we debrief with a takeaway summary and then some questions and answers. So a lot of what we do as health services researchers is really thinking about what is the current standard of care and how can we then utilize different tools to promote evidence-based, high-quality patient care. And what we know is that this is really important, but also sometimes what can be hard is to really be certain what the standard of care is and make sure that it's truly an evidence-based practice. And so for me as a health services researcher, what I realized was that really learning what happens upstream of figuring out what the evidence-based practice is really important, because not all guidelines are created equally. And this can have a significant impact on stakeholder consensus, for example. So we're going to focus on this top part, which is systematic reviews and meta-analysis, utilizing grade methodology and guideline developments. So what is a systematic review? The Institute of Medicine defines it as a scientific investigation that focuses on a specific question and has explicit pre-specified methods to identify, select, assess, and summarize the findings of similar but separate studies. And it can include a quantitative synthesis, which is called a meta-analysis, so it depends on the available data. One of the most important things of a systematic review is to really define the research question. And in a couple slides, I'm going to give you an example and ask you to think through how you might structure that type of a question. And so part of that is developing a protocol. And this is really done a priori to reduce the risk of bias. So we're not necessarily reporting everything that the evidence base says, but really what we think are patient important outcomes and what is clinically relevant to the care that we need to provide. So that helps us define our scope of our review, and it guides our search, how we're searching for studies. After we do a systematic search that is, reproducible and transparent, we screen the studies. Oftentimes that's done in duplicate. Then we synthesize these studies. It can be done narratively. When we do it quantitatively, that's when we often use meta-analysis. And then a really important part of systematic reviews is assessing the risk of bias. And that really has to do with what are methodologic flaws in the study that could affect the quality of the findings or the bias that is related to certain outcomes in the evidence base. And so I don't know how many of you have heard of the PICOs or PICOTS criteria in a systematic review, but essentially what that stands for, it's an acronym. So P is for population. I put here patients, but not always patients. It's usually, but not always. That's a primary component. The intervention. So this is often, if your question is, what are the most effective therapies for preeclampsia, for example. Intervention would be the types of therapies, and you would specify, are you looking at, medical therapy, surgical interventions, et cetera. What comparators are you looking for in your protocol? And then outcomes. And so usually we don't limit our search by outcomes, but we do pre-specify them to avoid a risk of bias. So we're not looking to cherry pick outcomes. We really want outcomes that are typically clinically important and of greatest interest to decision makers. The last two components are timing and setting. These are not required parts of the protocol, but it does help to specify it just to have a very thorough search, and also so that you, if you're doing the protocol, and the decision makers are on the same page about what you're looking for. So timing is, when is the intervention being given, and the setting is, where is it occurring? Is it inside the hospital, outside of the hospital, et cetera. And sometimes setting can also include, we're going to look at only US studies, or higher developed countries on the Human Development Index, et cetera. So I like to give this pragmatic example because I think it's just helpful for people to think a little bit about, like, what does this mean in real life and for a health system? And a lot of us do work in health systems. So back in 2020, we had the CMO of Penn Medicine ask us to synthesize evidence around increasing workplace violence. So I know it's not a maternity example, but I'm sure many of your institutions, you may have had similar issues where there was workplace violence in a healthcare setting. So one of the things we had to think through was, how would we approach developing our PCOTs, and what would this mean? And usually when I'm in a classroom setting, it's easy for me to call on people and ask you guys, what would the P be? But since it seems like, lots of cameras are off, I can just talk through some of our thinking, but I'm hoping that when we get to breakout sessions in 10, 15 minutes, we can get our cameras on and try to interact a little bit more. So as we're thinking about the PICOs, so the P is a population, you could imagine that we would say, okay, we're only looking at workplace violence for patients, for example, but we might also be interested in healthcare workers. And what if the violence occurs with visitors of the patients? Do we want to include that in our review as well? So you can already see how just with the P alone, you could have a very different scope depending on how you define it. Interventions, maybe we're interested in looking at any interventions that could reduce the incidence of workplace violence. So, maybe they're for interventions. We don't need to be too specific, even thinking about outcome, but we need to make sure that what the report we're giving her is actually useful to her. So we might ask a question like, okay, are you interested in just looking at frequency of events? Are you interested in looking at, a healthcare worker, like occupational well-being or adverse events or personal well-being, if it's a patient or visitor, those kinds of things. So these are all the things we had to think through. And I'm going to show you, this was what our protocol looked like. Julie made this protocol, and she's one of our experts on the call. And you can see here how it was defined very clearly that our aim was to identify and summarize evidence on the effectiveness of interventions to both prevent and manage workplace violence events in healthcare settings. So the P is kind of what I went through, and outcomes, it wasn't just looking at frequency, severity, recording of these events, but also, not surprising, a health system leader would be interested in some other outcomes, like how does it affect hospital stay, readmission, mortality. And then, like I said, we looked at well-being. One of the other things that we did here was we actually limited the study design, which is another thing you can do in a protocol, to only look at existing guidelines or systematic reviews. And that does allow for the review to be done a little bit more quickly rather than having to look at all original research that's done. And the other thing I just want to highlight here is the databases that she searched. And we're going to talk a little bit about that and how to look for guidelines and existing systematic reviews too, when you're trying to figure out what is an evidence-based practice that I want to implement in my research setting. And the study quality assessment, that's a big part of it. And that's what we're going to workshop today. So that's the systematic review. And, we're synthesizing evidence base. And then if we can do it quantitatively, we do. But then there's the decision-making part. And that's where the guidelines come in to play. And a guideline is defined as systematically developed statements to help clinicians and patients have appropriate healthcare for specific clinical circumstances. And there's another IOM definition that really talks about the importance of assessing the trade-offs and benefits and harms when you're making a recommendation as well. So this is the Institute of Medicine report that does that. And they also highlight these 8 things that are really important. And I really bring this up because not all guidelines are created equally. And even though this is the gold standard for what the Institute of Medicine states we should do, you'll see as you're looking through your guidelines that not all of them do all of these things. And so it's really helpful for us to think about what that gold standard should look like and then critique or worry or wonder about areas that bias may be introduced and how that it could affect the implementation side as well. So it's really important that we have transparency, both in terms of methods and funding. Managing a conflict of interest is a really important one. I'll tell you, as a gastroenterologist, I've served twice on our American Gastro Association Clinical Guidelines Committee, and this is always an issue. We have so many people who are conflicted because they receive direct payments from pharmaceutical companies, for example. So you can imagine if we're putting these people to chair a guideline on therapies for a condition that they, have direct conflict with, it can be a problem. So we actually really encourage more divestment rather than disclosure, meaning if you have a conflict for 3 years prior to the onset of that guideline, you should divest and get rid of that conflict. And also, we usually do 2 to 3 years after the guideline as well. And then who's in the guideline development group? Is it a multidisciplinary group? Is it a diverse group? That's another important aspect. All clinical guidelines should be based off of a systematic review. So that's very different, for example, than an expert opinion statement where a group of people come together and say, based on our anecdotal experience and maybe based on some cherry-picked studies that we've written or we've happened to have read, here are some guidelines. So whereas the gold standard of a clinical practice guideline really should be based off of a systematic review. There's a formal method for rating strength of recommendations. We're going to talk about that on the next slide. And then those recommendations need to be articulated in a clear and actionable way. It's also really important that there should be external review of the guideline. And you'll see that a lot of professional societies do have a public comment period, as well as peer review that happens even prior to publishing in a peer-reviewed journal, where it may undergo another round of peer reviews. So if you see that, it's actually great to hear from people like you who are on the ground doing implementation science research, but may find that there are issues with the guideline. You can submit a comment and they will take that into account prior to publication of the final guideline. And then the last thing is that it should be updated. And especially during COVID, we saw this where we would write expiration dates on our guidelines because we knew that it would become quickly outdated. So how do we go from evidence, which is a systematic review, to actually making decisions? Well, we use something called GRADE methodology. Normally I stop for a show of hands to see who's heard of GRADE, but we'll talk a little bit more about that in the small group. But GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. Essentially, it's a methodologically rigorous, transparent, and practical system to develop guidance documents. New, I guess now it's been a decade or two, so maybe I'm just getting old, but approach to rating quality of evidence and strength of recommendations. And prior to the development of GRADE methodology, which was, really important, especially as we're thinking about the new Institute of Medicine recommendations, a lot of what the historic thought was that you had data from a randomized controlled trial that immediately was strong data leading to high level or a strong recommendation. If it was an observational study, you were going to have a lower level recommendation. But GRADE does something that's much more holistic. First of all, it recognizes that study design is not the only factor that goes into assessing the quality of evidence, but it also recognizes that there are other pieces of the puzzle, which include patients' values and preferences, balance of benefits, harms, and burdens, resource use, equity, and feasibility. And one of the reasons I really love to talk about it with an audience like this is because I really want, as you're starting to read your guidelines, to see whether a guideline is mentioning GRADE. Are they using GRADE? And is it meeting that rigor that, we should be meeting these days under Institute of Medicine standards? And so some of you may have seen this, old pyramid of evidence, which had straight lines here. And just basically the concept is that the bottom of the pyramid is lower quality types of studies, and the top of the pyramid is higher quality, where you have case series or reports, and you're going to case control, cohort studies, randomized control trial data, and then recognizing that systematic reviews synthesize all of these study designs below here. And when it does it quantitatively, it's meta-analysis. And what grade does is they recognize these are not necessarily straight lines, and that there is heterogeneity in study quality. And I think especially for those of us, like now we've grown up in this era of big data, we know that a poorly designed RCT that is not blinded, is they don't have great resource allocation concealment, all of these things. It could be a poorly conducted RCT, but a really big data study that actually is a little bit more real world in terms of data and maybe uses causal inference techniques may actually be much more meaningful to the work that we're doing. And so grade helps us think about how we're conducting our reviews through that lens, and then using this as the basis for a guideline. So how do we now extract data from our systematic reviews and align it with grade? Well, grade and the protocols that we're using, like I said, have to pre-specify our outcomes. So if you're reading a study and these studies do not include the outcomes that were pre-specified, we are not extracting those data. So they have to be outcomes. So one example that I give is that, like right now, we're doing a project on therapies for stomach cancer. And if we only were interested in looking at overall survival and progression-free survival, but if a study is not reporting either of those two and they're looking at recurrence-free survival or only adverse events, for example, we won't have survival data from that study, but it's okay. We can take other outcomes that were pre-specified from there. And then we rate each of these outcomes across studies in terms of their quality, and we look at our certainty in the evidence that it presents. This is a figure that is admittedly very busy, and I always hesitate to present it, but it is one of the core figures of grade. So I just want to talk through it really quickly. You're formulating your research question with your PICOs upfront, selecting outcomes, rating their importance, so critical or important. So these usually critical is something like mortality, and maybe less important might be something like recurrence-free survival, or something that for a patient, like maybe a little bit less important. You're pulling all these outcomes across studies, and then you're synthesizing them in what we call an evidence profile. I'll show you an example of what that looks like. And then we go on to rate the quality of the evidence, and there's various factors that we can use to increase or decrease the quality, what we call grade up or grade down. And these factors are listed here. And in our epidemiology courses that are a year long, we have an entire lecture about each one of these individual aspects. But for today's talk, I'm going to just mention that they are there, and I'm happy to chat with anyone afterward about those details if interested. And then after the systematic review is conducted, the guideline panel starts. And so what the systematic review team does is they'll rate the overall certainty of evidence and then give it to the guideline panel, who will then formulate recommendations for or against specific, usually it's whatever specific intervention. They rate them. Are they strong or weak? And they consider all of those, those four circles that I had shown you, which are repeated here. And the language that's utilized is recommend or suggest. So either recommend or suggest, or recommend against or suggest against using. And you'll often see these in guidelines, which talk about, conceptualizing quality. So if it's high quality, we're very confident that the true effect lies close to the estimated effect that we've reported here. And then so forth. So moderate, moderately confident, low, our confidence is limited, and then very low, we have very little confidence. And you'll see these symbols and plus signs, and that's what it means next to in an evidence profile, which looks like this. This is also a little bit of a busy slide, but I just like to throw this up here because oftentimes you'll see a guideline that doesn't say they use grade at all, or maybe they'll use grade, but they don't have an evidence profile, which is really the way of showing your work that you used grade. And so I tend to tell people, if you don't see an evidence profile, you have to really, question whether they, did their work as thoroughly as they're saying they did. So the way evidence profiles are organized is by outcome. And again, that's because we look at this outcome across all of the studies, and you can see that not all of the studies may include it. So in this case, it was just one study. And then you have all these different buckets to look at quality assessment that affects the overall quality of evidence. And then this is where it's quantitatively analyzed, and you can actually see here it's hazard ratios and risk ratios here. When an evidence profile does not have meta-analyzed data, this is what it might look like if it's a narrative synthesis. But it's categorized by outcomes. And you can see here like how many studies reported these outcomes that went into the assessment, and then the impact is just summarized narratively in a paragraph format instead, but still synthesizing some of the evidence that's there. All right, so this is how we're actually getting to the strength of the recommendation, like we talked about, taking into account quality of evidence, but also these other factors, the balance between benefits, harms, and burdens. And the two big recommendations we see are the strong recommendations and conditional recommendations. Some people, instead of conditional, use the word weak. So can you all try to think about one example of a strong recommendation where most people in the situation would want the recommended course of action and only a small proportion would not? The one that I always give as a gastroenterologist is colonoscopy or colon cancer screening for individuals above 45 years old. So it's really a broad, strong recommendation for everyone. And actually, a strong recommendation does not need to necessarily apply to the whole population, but it's just that the quality of evidence supporting that decision is high quality and strong. And then I'll also mention that occasionally you can have a strong recommendation when the quality of evidence is not very strong. And typically we see that when the harms are significant. So this happened in the COVID-19 pandemic when there was, for example, you can have a strong recommendation to use an N95, even if the data quality weren't that good, because the harms of getting COVID-19, especially prior to vaccines, were notable. And then a conditional recommendation means that the majority of people in this situation would want the recommended course of action, but many would not. And a good example of that, for example, is prostate cancer screening. And I usually think of these as more shared decision making. You can see that here as healthcare workers. It should be consistent with their values. You can use decision aids, et cetera. So in summary, using GRADE, which is a transparent and systematic system, enables organizations to produce methodologically rigorous guidelines. And it allows us to reduce risks associated with poorly planned and executed guidance. And this picture here really just shows many of the professional societies that have adopted GRADE methodology or some modified version of GRADE. So pretty widely adopted. I'm going to turn it over now to Dr. Matt Mitchell to present these slides. And we're going to talk through how to find and evaluate guidelines, and then how to look at guideline quality, and then we'll break out into sessions. Matt, it looks like you're muted if you'd like to unmute, and then just let me know when you want.
Just fix that.
Thanks.
Okay, is that better, Sasha?
Perfect.
Okay, great. Well, we're going to talk next about several places to go and find guidelines. None of these sources are 100% comprehensive, so it's a wise idea to be using multiple sources when you're looking for guidelines. We'll talk about the ECRI Guidelines Trust, and I think I'm going to try to pick up screen here.
I'm not sure you'll be able to control it, Matt, but if you just say next slide, I'm happy to.
Okay, I think we got it now. Okay, there. Okay, so we have the first place that you should be looking are the professional societies that are relevant to your topic. So if it's obstetrics, it would be ACOG, the British College of Obstetricians and Gynecologists, sources in Europe, sources in Canada. Don't rule out those non-US sources, because frequently they'll give you a different perspective. They may have more recent guidelines, and they may have stronger, more evidence-based guidelines. We heard first about the ECRI Guidelines Trust, and in a few minutes, I'll walk you through a little of that. There are actually two ways that we can access this. One is through the standalone site put out by ECRI itself. It's available for free. I think the free registration is needed to go and view the guidelines from that. But it's a good source. I should mention that I was present at the creation of the ECRI Guidelines Trust, which began about 20 years ago as a project for ARC's predecessor. We called it the National Guideline Trust. We got ECRI Institute got a grant from ARC to put this together, a contract. And when the contract was withdrawn about 5-6 years ago, ECRI decided that they would try to keep this going on its own. And so they had to monetize it in one way or another. And so what they've done is they've made the free site a limited evaluation of the guideline with all of the content of the ECRI guideline evaluation and their scorecards available if you go through a paid site. And so they have partnered with Ovid, with Lippincott. And the good news is that for those of us in the Penn Medicine system, we have access to it for free through the biomedical library. And in a moment, I'll walk you through how to get to that because it's a little bit complicated. Another source to think about is the Guidelines International Network, GIN. They have they're an organization of guideline developers that works on methods and on dissemination and evidence to practice. They're a good organization to be a part of if you're a guideline developer. They have an international guideline library. It is not as complete as the ECRI Guidelines Trust, but again, it's another place where you have sources that will not overlap that are going to give you additional places to find guidelines. I very much like the National Institute for Health and Care Excellence, NICE. They are the evidence-based practice wing of the UK National Health Service. They do a lot of evidence-based practice things, including systematic reviews and a very large collection of very comprehensive guidelines. And they show NICE guidelines are a good model to follow if you want to see a well-developed and well-documented guideline. Eventually, also, we've got the U.S. Preventive Services Task Force. We will have their guideline in here. And for those of you in the nursing field, the Registered Nurses Association of Ontario has a lot of useful guidelines as well. They tend to be a little more big picture, but think about them too when you're looking for guidelines. So I'm going to throw over for a moment here. Okay, everyone see the ECRI Guidelines Trust? Okay, great. So I thought let's just take an example here. If we look for preterm labor.
Matt, I'm the one sharing screen, so they can't see your screen. Do you want me to stop and would you like to share your screen instead?
I can see. I see myself screen. I am sharing.
He's sharing.
Great.
Oh, okay. I wasn't seeing it, but maybe now I will. Thanks.
Okay, so let's see. We have. Okay, how about premature rupture of membranes? So here is the ECRI Guideline Trust took you right to the guideline. And let's find the rating here. Okay, so there's our answer. Now, all we get from the free site is a link to the guideline itself. So let's go over to the paid version. And I'm going to get through to the biomedical library. And I'm going to look for preterm We'll do the same kind of search that we would be using if we were searching Ovid Medline. And then we have to change the search resource. We see this down here just above the search box where we're looking at the things that we're searching. We've called up different sources, and under the Lippincott Evidence-Based Health, we have the ECRI Guidelines Trust. So we'll run that search and see now we only have 33 guidelines. And let's scroll through and find that guideline for preterm labor. Okay, well, here's another one, prediction and prevention of preterm birth. So if we open this up in the Ovid version here, we should have in there somewhere should be the full evaluation by ECRI. Let's see if we have a trust, pick one with a trust scorecard. Okay, about chocolatics. Okay, good. Now this is what I was looking for here. This is the content that ECRI is adding, where they've given you an analysis of this. They've told us what the grade is. And down here at the bottom is a rating of the quality of this particular guideline. So that is what you look for if you are getting the ECRI scorecard from the ECRI Guidelines Trust. And now I'll throw over to NICE. And we have a lot of things that they do. What we're particularly interested in is their guidance. And we can search their guidance for particular topics. And I've already scrolled through to find, I close this tab. So now we have fertility, pregnancy, and childbirth. Let's get for intrapartum care. It's all very, very well organized. And so now we want to look at NICE guidelines. And here is the NICE guideline, national guideline number 25 for preterm labor and birth. So in this, we have a summary of the guideline, a downloadable guideline, a list of the evidence, and we see here the evidence reviews for all the different questions in here. And it's very, very thoroughly documented. So NICE guidelines are a good example to look at when you are looking for topics. Okay, so now we've seen a couple of the examples, and now let's talk about the tools that we're using to appraise guidelines. A few minutes ago, Shazia showed you a 2011 report from the Institute of Medicine called Clinical Practice Guidelines We Can Trust. And so when that came out, we knew we needed to have a better scale for appraising guidelines than the current standards that were out there. So AGREE was a very commonly used standard for appraising guidelines. It's a checklist with about 20 or 30 elements to it. It's very long, and it takes a lot of time to complete. So we thought we needed something that was a little more pragmatic, something that was quicker to do, and more useful for the end user as opposed to the author of the guideline. If you look at AGREE, if you look at PRISMA, if you look at START and all those other standards, those are written mostly for the people who are writing the guidelines. So they tell you, put the word guideline or guidance in the title. Make sure that you've done this, make sure that you've done that. And most of those have to do with reporting rather than whether the guideline itself is worth using. And so we started our own tool based on that IOM standard that had 6 axes, and we picked one axis, made one question to go with each of these axes. Our methods are transparent. If you look at the SEP website, you will find a nice rubric for building that. And then I want to call out the table that you see down there. This is a guideline appraisal table. And I want to talk more about how to interpret this than how to turn the crank and actually fill in that table. These scales should not be a checklist. They should not be. Notice on our table that we do not have anything where we've got a final score. We're not adding up the number of good check marks. We're not adding up points. Instead, we're letting the table stand on its own. And that's important because any kind of point system is going to end up relying on somebody's subjective judgment about what's important and what's not. So it's not as objective a tool as you think it is. Instead, we want you to look at the guideline set as a whole. And if we see this graph in 2 dimensions, it tells us 2 things. First, if we look in the vertical, we can ask ourselves, which of these guidelines seems to be the one we can trust the most? And clearly the Italian guideline has got a number of problems. We've got some red marks in there saying maybe these are problems. And the American College of Cardiology, Cardiac Something Society, those seem to be better guidelines. And so we can look through these and pick which look like good guidelines and which don't. But we also can look in the horizontal direction and look at the guideline base as a whole. Where are the problems that all of the guidelines have? Where are the strengths that all of the guidelines have? And if you see that there's one aspect of a guideline that everybody seems to have problems with, and let's look at now at the bottom, that almost all of the guidelines have a problem with being out of date. And so from our perspective as decision makers, we want to look cautiously on that. We may ask ourselves, is there new evidence that might cause us to change to do something differently from what the guidelines would say? Another problematic aspect across all of these is line number 3 about the development group. And that may tell us that maybe we need to be looking at different perspectives and not just one perspective in this. So we've borrowed this for those of you who are old like me. If you remember the Consumer Reports magazine, we have the same kind of tables like that, where we have an easy comparison chart. And we've written these in such a way that for all of the SEP evidence appraisal tools, our guideline appraisal tools, our RCT appraisal tools, our systematic review tools, that if you see an A or a yes, those are always good. And if you see a C or a no, those are bad. And we use colors to make it easy to spot those differences. So let's look into the specific elements of the trustworthy guideline scale. And I want to talk more about the whys of each of these and how we should think about weaknesses and strengths in each axis as opposed to talking about turning the crank. So the first line is about the transparency of the methods. We want to know exactly how the developers made their decisions, how they considered other perspectives, how they looked at the evidence. Because if this isn't discussed, then you have a concern that maybe there wasn't a robust method and there was an opportunity for bias. That if you had a black box, then it could just be, what is the preferences of that committee that developed the guideline? So that's a risk for bias if we don't see a good, clear methods description. Now, I'm going to add also a couple of pearls for each of these particular questions in our trustworthy guideline appraisal. And these are to help you when you are evaluating the guideline yourself. And one of the most important things is that many guideline issuers will have a separate document talking about their process. And so if you don't see the methods discussed in the guideline itself, go back to the issuer's website and see in their guideline section, do they have some kind of methodology document? Do they have a web page that says this is how we do it? If ideally, they'll have a citation to it in the guideline itself. So you look there to find that. But don't immediately assume that the methods aren't documented if you don't see it in the guideline itself. Second is the conflict of interest. Now, that's an obvious source of bias. If somebody who was on the panel has a financial interest in one decision or another, one action or another that you, the guideline user, are taking. And so guideline developers are usually good about documenting, did they take any funds from companies that are involved in this field? But the conflict of interest can go a lot deeper than that. And it's a rabbit hole. We can talk about the conflict of interest of somebody who has a grant funding research in a particular topic. They want to believe that their research is making a positive difference. And so they'll bias their view to support what they think they're doing. And so that's not an easily disclosed. It's a difficult guideline, difficult source of bias to try to tease out. So our job here is to be pragmatic about this, to be practical. Now, sometimes you'll have people who have taken, who are disclosing a lot of different financial relationships, none of which happen to involve the question at hand. So there, you may decide that even though there is a conflict that is disclosed, that it's not really putting the guideline at risk. Another problem is that when we have a very large guideline panel, it may well be that 3 or 4 of the members have one kind of financial conflict or another, but the majority don't. And if you look at the guideline methodology, you may see those people recuse themselves from the decision. So don't just look at the disclosures at the end of the document or at the beginning in the footnotes. Make sure you think about that a moment and ask, does it really cause us a risk of bias? Now, one of the aspects a nuance that was brought up in the IOM standards that is worth thinking about is the fact that for many conditions, we have different people in different specialties who have their own perspective on this. So you may have surgeons versus people who are doing endoscopy, that each of them are going to be advocates for their particular solution, their particular treatment, their particular way of approaching a patient. And so a good guideline is going to take representation from both of those specialties, from anyone who's involved with this, instead of limiting itself to just one perspective. And so that's another possible source of bias. Now, what else comes up in the rubric that we use for our trustworthy guideline appraisal is that we're looking for best practices. And best practices have been that the IOM really believes that patients and other lay people, advocates for patients, should have some kind of representation in guideline development. And so you'll actually find very frequently a lot of good guidelines end up missing out on this particular question, on this particular representation of lay people. So we may find that if there's a negative or a B grade on it, that it may not necessarily be dooming the guideline. All right, obviously guidelines need to be based on evidence, and we want to see a good quality systematic review, because if the evidence is limited, then it could be that the authors of the guideline panel brought the papers that they think are important, and then all that's going to do is reinforce the author's point of view, and that's a source of bias. So clearly, we want to find a systematic review. And again, and this is clearly the case with NICE, for instance, the evidence review is frequently a separate publication from the guideline itself. All right, so now we'd like to know, is the evidence strong or is the evidence weak? Because if the evidence is strong, we're likely to be having a lot more confidence in that guideline. We're much more willing to make decisions based on what the evidence says. But if the evidence is weak, then that's when we have a chance to be considering other factors. We talk about local preference. We talk about what the patient's preference is and how that may go into local decision-making. And it's okay if the evidence is weak to be bringing in other questions, other factors. So just one more pearl here, that remember that when we're running through the trustworthy guideline appraisal, we're evaluating the guideline itself. We're not evaluating the evidence. So just because the guideline developers said that for a particular question, the evidence was lacking, and we have to make our decision based on an expert opinion. And you'll see that rating of the evidence, the rating of the conclusion, that even if it's based on expert opinion, if they looked for the evidence and didn't find it, that's still a trustworthy guideline. In fact, it may be even more trustworthy because they've been willing to say, this is where the evidence ends, and this is where we have to make decisions based on on expert opinion. Okay. Item 6 in the trustworthy guideline appraisal is about the recommendations. Are they graded? They talked about that a few minutes ago, about whether the strength of the recommendation is a strong recommendation that should be done or a weak recommendation that should be considered in light of other conditions. We also would like to have recommendations that are actionable. And the key things that we want in making a guideline actionable are telling what to do, to whom, and when, and how. So if we see specific drug doses, if we see test thresholds, those are good examples of actionable guidelines. If we see a pathway or an algorithm, that's a good actionable guideline. If we see bullet points, that's probably going to be an actionable guideline. Item 7, and this is again coming out from the IOM standards, is that we'd like to make sure that there's been a fair and open review process. We want other people who may have a different opinion, people who may have a vested interest in this, the patients themselves, the other practitioners, to have a say in this guideline, that once the draft guideline has been put out, they're listening to external opinion. This is a hard one. Some guideline developers will put their draft guideline out to members of that society only, or just to the officers of the society. And that's not a full open review. So we want to ask ourselves, when we look at how the issuer has described their review process, is it something that they're really willing to listen to dissenting opinions? And then the last item is about whether the guideline is up to date. We have at CEP a kind of arbitrary threshold of 3 years, but we're also willing to shape that up or down if we have an emerging topic or a topic that's been settled for a long period of time and we don't see a need for getting new evidence. As long as there's some kind of process that they're checking for new evidence, that's a good thing. So in the rubric, if the guideline is outdated, it's automatically a C. It's automatically a red mark, and because we want to tell our users, look for new evidence. But if the guideline is reasonably current, but there's not a process for updating it, then that's a less trustworthy guideline.